Welcome to Medicine and Science from the BMJ. I'm Cameron Abbasi, Editor-in-Chief of the BMJ. This week, armed conflict is jeopardising the provision of critically needed healthcare, such as in Gaza and Lebanon. We hear about the risks braved by healthcare workers who face injury and death to help those who are most in need.
We've recorded around 7,500 attacks since 2018, and associated with that, around 2,500 deaths and 5,000 injuries. And we all know deep within us that attacking health really crosses a line that just goes too far.
We take on one of biomedical science's greatest sins. For decades, medical researchers have neglected women in their studies. We'll hear how that affects the evidence base and how the BMJ is trying to help make up for lost time.
Even diabetes, which generally is more prevalent in men than women are at greater risk of the associated mortality and complications. They have higher risk of stroke and coronary artery disease. And even despite that, are less likely to receive the care recommended by clinical guidelines. So there's a real mismatch there.
And we talk about how to rejuvenate palliative care.
Palliative care as a specialty cannot and should not see everybody that has a life-limiting and life-threatening condition. That's not feasible. They are there to take complex cases, to give mentorship, training, education, but we really need palliative care to be trained and delivered as the responsibility of all.
Protecting Health in Armed Conflict is the title of a new report published ahead of the World Innovation Summit for Health. It speaks to one of the most pressing issues in global health today. Our partnerships editor, Paul Simpson, spoke with the report's author, Dr. Richard Brennan. Richard's work as an emergency director at the WHO covers 22 countries around the Eastern Mediterranean, including Palestine. The discussion starts with what constitutes an attack on healthcare.
Attacks on healthcare, they haven't just started in recent years. They're as long as conflict has been around. But we're really seeing an increase over the last few years. So an attack on healthcare covers a range of issues: physical attacks on health facilities, physical attacks against healthcare workers and indeed even patients, but not always physical attacks as such. It can include detention of health workers. It can include intimidation, arrest or kidnapping of healthcare workers and patients. It can include attacks on not only health facilities, but also ambulances and other forms of medical transport. And it can include obstruction of people's access to healthcare. So when we talk about an attack, it may not necessarily mean a bomb has been dropped on a hospital. It may mean that a healthcare worker has been stopped from going to their place of work. It may mean that patients have been obstructed from getting access to healthcare. So again, broad range of different types of events.
Would you mind describing, how that plays out? What are the trends?
So the trends is not like a progressive increase over time. What we have documented is that usually in the early stages of a conflict, when the levels of violence have escalated, that's when we really do see the peaks in the numbers of attacks on healthcare. We've seen it in Congo, we've seen it in Ukraine, we've seen it in Gaza. No doubt it'll be a similar situation in Lebanon. And after that initial spike, we do see a fall off. When the readers look at the report, they will not see graphs with progressive trend lines in a particular direction. They'll see spikes that correlate usually with the onset of the conflict, which is often associated with the highest level intensity conflict and also a bit more of a chaotic operational situation on the ground.
People will be very familiar with the headlines, with the shocking sort of initial direct consequences of an attack, but they might not be familiar with the kind of grinding long-term consequences.
I mean, we have, I guess, what you could call the direct and the indirect consequences of attacks on healthcare. Since WHO started documenting attacks on healthcare, we've recorded around 7,500 attacks since 2018, and associated with that, around 2,500 deaths and 5,000 injuries. For example, in Gaza, since the 7th of October 2023, we've documented 516 attacks on healthcare, and that's been associated with 765 deaths and 990 injuries, and that's up until today, the 28th of October, 2024. In Lebanon, where we've seen a real escalation, since the start of this month, we've seen 25 attacks on healthcare and associated with 57 deaths and 18 injuries. So it gives you a sense of the scale. And what's shocking about this, I think there are international laws, of course, against attacks on healthcare. But it's not just that. We all have a strong sense of what's right and wrong. I mean, some people talk about the sanctity of healthcare. And we all know deep within us that attacking health really crosses a line that just goes too far.
Attacks on healthcare are not new. They've been going on for as long as probably there's been healthcare and there's been conflict. But we are in a space where there are established mechanisms that are supposed to reduce the amount of attacks that happen. Would you walk listeners through what they are? What are these established mechanisms?
Sure. And again, we're talking about attacks on healthcare within the context of conflict. There are rules to conflict, and they are laid out in the Geneva Conventions. And there it's very, very clear that health facilities, health workers, the sick and injured must be protected and cared for. It is not right to say that all is fair in war. There are rules, and even though these have been codified with the Geneva Conventions, there have been the old concept of the warrior's honour, that you do not abuse the sick, the wounded, the injured. So the Geneva Conventions are also called international humanitarian law. They lay out the legal obligations of military forces in the setting of conflict, and specifically they address the issue of protecting healthcare. They're not the only international instrument that does so. The right to health is also well established within international law and in a number of different documents. And there's even a UN Security Council resolution that calls for the protection of healthcare. So protecting health in conflict, the right to health generally, the UN Security Council, there are a number of other documents, but these are all well established in international law that healthcare has to be protected in conflict.
I guess it starts to bring us to the findings of the report and the recommendations from the report.
Yeah, so I think that what the report does, it sort of lays out the scope and scale of attacks on healthcare. It describes the impact on the availability of health services. So, for example, right now in Gaza, only 17 of 36 hospitals are functioning, and they're only partially functioning. In Lebanon right now, there are 9 hospitals out of action. And a large part of that reason is because of attacks on healthcare, but also because of evacuation orders and disruption of supply lines. Then the report lays out ways to protect healthcare. And there are legal mechanisms, international humanitarian law, the Geneva Conventions, UN Security Council resolutions, the right to health. There are also accountability mechanisms, bringing people to account through criminal prosecution. The UN Security Council can also issue measures such as sanctions, arms embargoes, and so on. Different UN bodies can actually name and shame perpetrators. So these are all mechanisms that are designed to prevent attacks on healthcare. What we've noticed is, despite all those mechanisms, there hasn't been a decline, as it appears, in the number of attacks on healthcare. And despite all those mechanisms, of the 7,500 attacks on healthcare that WHO has documented over the last 6 years or so, not one person has been held to account for any attack. It's not just legal mechanisms that we use to protect healthcare. Frontline health workers are being very adaptive. When you have active conflict around your health system and your health facility, you've got to find ways to ensure that you can continue the delivery of essential health services and also rise to the occasion when the next flood of perhaps injured patients come in. Setting up field hospitals, decentralising the delivery of healthcare, reinforcing health facilities, putting in early warning systems, building bunkers, training staff on evacuation measures, training staff to engage in health diplomacy so they gain the trust of local communities, and on occasion, as appropriate, to also engage as constructively as possible if the opportunity presents itself with the warring parties themselves. So we need to be doing a lot more. I mean, the scale of attacks on healthcare right now is so shocking, so disturbing, that we've got to find a new way.
Aside from the legal mechanism seemingly not working, you've mentioned already that despite the thousands of documented attacks, there's only a handful of those that are accused that are held to account. There's a sense of a kind of shamelessness. So the shaming mechanisms do not seem to be working either. And I guess that what readers and listeners will want to know is what can we do? And what do you have to say in the report about that?
I mean, I think the report serves a number of purposes. Firstly, we want to raise the awareness of this shocking development in armed conflict today. Secondly, we want to propose concrete, actionable measures that we feel can improve the situation. So we're seeing the report as a way to restart a lot of momentum on addressing the issue. So the report has 9 recommendations. I won't list them all, but what we have done is we've categorized them as steps to be taken at global level, which are largely political in nature, steps at national level, which are around capacity building and awareness building, and then steps at local level, which are really concrete steps to physically protect facilities and engage communities. So at the global level, we're recommending the establishment of a global alliance for the protection of healthcare in conflict, and that would engage key stakeholders with influence who can leverage their political, legal, economic capacities to advance the protection of healthcare, including putting an end to impunity. We're also recommending that the United Nations establish a UN Special Rapporteur on the protection of health in armed conflict. And again, that person would also be leveraging those different types of capacities, being the key advocate for advancing protection of healthcare, and again, the key advocate for putting an end to impunity. We also want to intensify diplomatic efforts, have governments engage more rigorously on the diplomatic level on these issues. At the national level, we want to educate armed forces more thoroughly on their obligations under international humanitarian law. And then again, at local level, giving guidance to healthcare providers about how they can make their health systems more resilient and also how they can engage communities so communities feel a responsibility for the protection of healthcare. We believe the recommendations are concrete. We believe they're actionable. And now we just have to move forward and make sure they're implemented.
So we're coming to the end, and I was thinking about our listeners. So many of our listeners will be practicing doctors, but they'll probably be practicing in relatively calm, relatively peaceful contexts. But they'll also be aware of the headlines. They'll be aware of reports like this, and they're probably going to be very moved by it. What can they do if they can't actively be there? What's the best thing that the kind of medical profession outside of conflict zones can do to support those that are struggling?
Well, I think advocacy is always helpful, keeping issues on the agenda and advocating with their local members of government to influence government policy on this issue. Some of your listeners may want to volunteer for humanitarian agencies or human rights agencies. They can make financial contributions as well. So there are very concrete things that individuals can do. I think we really do need to push our political leaders to put an end to the impunity. We need deterrence. To have the politicians use, again, their political and legal and economic leverage to bring an end to the impunity. That's what we need, I think, more than anything else. But again, concretely, volunteerism, advocacy, financial and other types of contributions, all of those measures help as well.
And that was Paul Simpson for the BMJ interviewing Dr. Richard Brennan, WHO Emergency Director for the Eastern Mediterranean. I'm joined by 2 colleagues from the BMJ. I have with me Menaka Paranathala, one of the BMJ's newest clinical editors, and Menaka has a feature on the way on the historical and current dearth of women participants in research. I also have with me Emma Rourke, another one of our clinical editors, and Emma's been involved with a UK-based project to bring these issues to the fore. So welcome, Menaka and Emma. Menaka, I'm going to start with you. Tell us about this feature that we'll be publishing soon.
Yes, it's a very exciting project that I've been hearing about from the George Institute at Imperial. It's called Message, and the aim is to highlight sex and gender equity in the design of research. It's a policy project that will be implemented by funders across the UK, and they're hoping that will begin this autumn, looking to kind of redress the balance in sex and gender equity across medical research. It's a real problem, and I don't know if many of our listeners will really know about the stats of the basic science. So if we look at cell lines in animal research, it's actually 5 times more representation of male cell lines in animals than females. And even when you look at more clinical studies, so phase 1 clinical trials, it's only around a fifth of these participants who are women. So it's a real problem that spans research, clinical and basic science. It's exciting that the UK now has begun to bring in its own policies, because there are other countries like Canada, USA and Europe that have had policies for quite some time.
Yeah, I mean, clearly at the BMJ, we're much more focused on the clinical end of the spectrum. And it's not a new issue, is it? I think it's something we've known there is a problem with for a long time. Why has it taken so long to address?
I think there's been quite a lot of reticence about studying women, and there are issues around women of childbearing age, women who are pregnant, women who are breastfeeding, and there have been quite high-profile issues around drugs such as thalidomide, which was used as a morning sickness drug but led to a number of birth defects, and that's led to a lot of fear around studying these population groups. But as they do make up a big part of our population, it does leave a lot of people in whom we don't really have adequate information on how drugs might have an effect, and, various pathologies. There are plenty of women who are pregnant or breastfeeding, or say want to get pregnant and may have long-term health conditions or require medications that, we haven't really studied very well the effects in these populations.
Yeah. So Emma, has this presumably come up in the meetings you've attended on Message? Has the risk side of it been discussed in your conversations?
So I would say that inevitably it's a consideration, and it came up in a number of the informal discussions, but the main aim of the Message project in its current iteration was to ensure that you're kind of correctly characterising who's involved in your research and thinking about the implications of that for the findings and how generalisable they might be.
So Menaka, I think there is some additional work taking place, is that right?
Yeah, so my discussions with Kate Womersley from the Message team, she told me about a sort of spin-off project, which is the Message Maternity, which aims to look particularly at this issue. So women who are pregnant and breastfeeding, who may have pre-existing conditions, maybe on medication, looking at how best to mitigate the risks, because we do need to study these populations, but we need to make sure we do it safely. So there's a real balance here. And, in recent years, there's been lots of discussion about drugs like valproate, and trying to avoid using them in women of childbearing age, but it is a very effective drug, so it does make it quite difficult to balance those two things up, and it's something that needs a lot of thought.
Yeah, but has the assumption shifted primarily from a hesitancy to involve women in trials and other research to saying, well, we must include women, but then thinking about any potential risks, of that particular drug? So that is a change of emphasis.
Yeah, I think that the default should be that we're looking in ways to diversify the demographics that we cover in our studies, because if you haven't included the groups, then you can't draw any conclusions. Excluding women as a blanket and women who are pregnant and breastfeeding probably doesn't solve the problem of working out how best to treat them, but trying to safely include them. And also women of childbearing age, should be allowed to make decisions about participating in research. So it's one thing that we discussed, that there is contraception available. People can make choices, and they should be allowed to partake in research.
Yeah, and what you started talking about there was the clinical impact, because if you're making clinical decisions, you need to have the relevant evidence for the patient that's in front of you.
Absolutely. It's really well established that with things like cardiovascular disease, that women are particularly likely to present with what we'd call atypical presentations of things like myocardial infarction. But, atypical for 50% of the population just means that it's just the way we're thinking about it and the way that we're describing symptoms.
Yeah, I mean, atypical, it's kind of atypical from a male perspective.
Well, exactly, if that's the measure you're taking.
Yeah.
And there are studies particularly on things like troponin levels. That's a key measure that are taken, and these are found to be lower in women. So if you use sex-specific thresholds, actually the diagnosis increases for women by around 40%. So that's a big change. These are important things. I mean, even diabetes, which generally is more prevalent in men than women are at greater risk of the associated mortality and complications. They have higher risk of stroke and coronary artery disease. And even despite that, are less likely to receive the care recommended by clinical guidelines. So there's a real mismatch there.
And I think it also plays into the teaching that you receive and everything that's based on, the impressions that we have, as Menaka was saying about, in acute coronary syndromes. It's well known that the symptoms that we look for now are more common in men and that women may present differently and have poorer outcomes as a result. So I think it's really good to shine a light on this.
How much, you talk about shining a light. How much attention is being paid to this? Is it something that there is a lot of noise about, that, this is an injustice and something needs to be done about it?
I think there's definitely a lot of enthusiasm. The Message Project have recruited stakeholders from across a wide range of organisations. There's been great representation from national funding bodies, medical research charities, regulators, academics, researchers, clinicians, as well as patient representatives. There's a huge amount of enthusiasm to make a change. And I think that's something that I've come across as well when I've talked to people at the BMJ about this. Everyone can see how actually making these changes and addressing this is good for science.
Menaka, you're a surgeon. How does this apply to your clinical practice?
In the population of patients I see, there are particular conditions like the chronic pain patients. So, we see quite a lot of them with the various spinal conditions and so on. And there's quite high representation of women amongst those kind of groups. And there is research looking at the way in which women's pain is treated. That spans kind of not just surgery, but, from maternity care to just, other etiologies of chronic pain. So there was a study that looked at male patients who, when they complained of pain, were given pain medication. But then when female patients complained of, the same symptoms, they were given sedative medication instead. And that's a very old study. And that's, been one of the foundations of how we've come to look at the differences between the way in which men and women are treated. So I think it's something that actually we probably all see in parts of clinical practice, but may not realise to kind of call out. And I think that's one thing that this does, is highlight to everyone. Because, we'll be clinicians, but, at some point we may be advocates for unwell relatives, or we might be unwell ourselves. And, these things will become apparent in different ways to us, I think.
So it's not just about women as participants in research or as patients. It's the whole ecosystem that there is a problem with. So women as researchers, as academics, being involved with funding decisions. Is that right, Menaka?
Yes. Across academic medicine in the UK, there are, there's a lack of women at the professor and kind of senior levels in research. So that does have an impact for kind of women who are coming through as researchers and scientists, and also for studies, for the way that they're designed and recruitment of women.
Yeah. Right, Emma, you've been working on the Message Project. What does this mean for the research that we publish in the BMJ?
We are going to ask researchers to think carefully about sex and gender considerations in their research reports, and to ask them, where appropriate, to disaggregate their data by sex or gender, and to describe the differences or similarities in a clear way.
Great.
And while we have talked about other international initiatives that exist, we are an international medical journal and we do receive papers from across the world. We also receive a lot of research that uses existing databases that already have sex and gender recorded. It's not going to be straightforward, and there are a lot of considerations. And I think the aim here is to move in the right direction, accepting that there are going to be things we need to address along the way.
Okay. Emma and Menaka, thank you both for joining us. Look out for Menaka's feature on bmj.com, and you'll also find a link to the Message Project in the description that goes with this episode. Next, Paul is back, turning his focus to palliative care. Palliative care is very topical at the moment, particularly in relation to assisted dying. But the focus of this conversation is about meeting the global needs for palliative care. Could its integration into all specialties be the key to change? Over to Paul to find out more.
Palliative care is an overlooked global health priority. That is the message of a new opinion article published in the BMJ and a report that will be published by the World Innovation Summit for Health later this month. I spoke to the team that wrote the opinion article to find out more.
So my name's Richard Harding. I'm the Herbert Dunhill Chair of Palliative Care and Rehabilitation, and I'm based at the Cicely Saunders Institute at King's College London.
My name's Anna Peeler. I am the Cicely Saunders International Postdoctoral Research Associate at the Cicely Saunders Institute, and I'm also a nurse.
And I am Oladayo Afolabi, and I am a postdoctoral research fellow affiliate with the Cicely Saunders Institute, and I'm also the senior analyst for the Palliative Care Network within Nova Scotia in Canada.
So you're all authors on this new report for the Wish Conference on palliative care. And the report opens with a statement that there's a common misconception about what palliative care is. Richard, I wondered whether you might start us off and tell us, what is this misconception? What is palliative care?
So the interesting thing is palliative care, of course, originated with Dame Cicely Saunders as the leader of the modern hospice movement in the 1960s, when she realised that cancer patients at the end of life were receiving inappropriate care or not receiving care responsive to their needs. So what happened then was a clinical discipline emerged, which was focused on the end of life. But of course, that person-centred, detailed approach to assess symptoms and other concerns, to be patient-centred, to be family-focused, has much earlier benefits for people living with a progressive condition. So in recent years, there have been a number of randomised control trials that have shown that the earlier you integrate palliative care, the better. And that does not mean that you have to remove disease-oriented aggressive treatment. You don't. You can be managing symptoms, giving psychosocial holistic support alongside disease-oriented treatment for as long as that's deemed appropriate. And trials, interestingly, have shown a couple of these early integration trials have shown there's actually a survival benefit as well. Actually, if you're not giving people very, very burdensome aggressive treatment, which is not likely to be beneficial, you can also have a survival benefit. So that's a real evolution in the benefits of palliative care.
Great. So it's good for patients, it's good for the health system. The report has a pretty stark statistic in it, though, that only about 14% of the global palliative care need is actually being met. Deo, I wonder if I could turn to you. Could you give us a picture of what that looks like across the world?
So the need is great and is disproportionately even greater in low and middle income countries. And because most of the people who have palliative care needs based in those countries where palliative care may not be available, it means that meeting those needs becomes disproportionate. And that is why you see that in the report that about only 14% of the need is met, because that is usually in the high income countries. And over the next 2 decades, we're going to see even the needs increasing more. And we hope that the inequity will not expand with that increasing need, because it will create a worse situation than we have now.
Would you be able to give us a sense of the types of diseases where there is a big burden now and how that's going to change over time?
So we know currently palliative care majorly, and that is one of the inequities as well, is usually more in patients with cancer, because cancer is more predictable. We understand the trajectories of the illness, and doctors can sort of say, this is the next phase, this is the next phase, and guide treatment that way. But in other conditions where the trajectories of the illness might go up and down over time, or might even just stay the same, and then a serious drop at the end, those conditions with less predictable trajectories are currently not being supported as well as they should be. So it's not just limited to cancer alone.
The headline of the report that you've written is that there hasn't been much progress over the last 10 years. Richard, why is that?
I mean, I think the first thing that's happened is palliative care was always seen as an additional add-on and non-essential service. What universal health coverage has achieved, which is, I think, a fundamental step forward for us, is that palliative care is now seen as an essential health service. It's an interesting challenge because, of course, in many parts of the world, including the UK, palliative care has emerged from within the hospice movement. And the challenge with that, when you're in the tertiary section, if you take the UK example, UK hospices are only 30% funded by the health system. So 70% of their costs are raised through public fundraising. But we know we're living globally in a context of limited resources. Health services are stretched. However, at the same time, we have an aging population. And the problem is, while people are dying, they're also living for quite a long time and using health services and having quite high needs on their families and their communities. So it's a major challenge that if we don't respond to this now, all the problems we see in the health service are only going to get worse because the number of people dying is increasing. We know that they are a major cost driver in the health service in the last year of their lives. So we really, really must respond.
So the report, of course, includes recommendations, suggestions for how we might start to address this issue so that in the next 10 years, we're not talking about 14% unmet need. Would you like to walk me through some of the recommendations, Anna?
Sure, I'm happy to. Well, so first to point out, a lot of progress has been made, but unfortunately the need for palliative care is growing so rapidly that our progress is happening nowhere nearly as quickly as it needs to. So some of the recommendations that we've come up with, they target different groups. So we have some recommendations for governments, national governments, local governments, the World Health Organization, for other multinational organizations like that. And then on a smaller scale for universities, for researchers, for people in general. So we start out pretty basic and say that every country needs some kind of evidence-based national palliative care policy that includes sustainable funding. We have a lot of evidence that shows that palliative care is effective. We know good models of care, but it's a struggle sometimes to find sustainable funding so that every person can receive palliative care services rather than just the people who can afford it. In general, there needs to be a little bit more public education and public understanding of what palliative care actually is so that people know the services that are available for them. And so that when people have the knowledge of what palliative care is and how it can benefit them, they'll be able to ask for it when they feel like they need it. We've talked a little bit about kind of integrating palliative care into healthcare services and how giving primary care providers the tools that they need to deliver palliative care services. This is the most equitable way to reach the most people. So that's one of our recommendations. To improve access to palliative care, there needs to be robust primary care infrastructures and training for primary care providers to know how to deliver palliative care services as part of their usual care.
One of the areas that the report focuses on is access to essential medicines. Could you tell us about that?
Part of palliative care, or a big component of palliative care, is managing symptoms. So whether those symptoms they're things like pain, nausea, fatigue, so symptoms that greatly affect people's quality of life. There are medicines that can help with that. Things like opioids are very cheap and effective ways to manage pain. But because there's fear around opioids and there's a lot of kind of regulatory constraints, people that could really benefit from essential medicines are not getting them. So a couple of our recommendations focus on encouraging governments and healthcare systems and healthcare workers to acknowledge the transformational benefit of low cost and effective opioids. We know that they're effective, we know that they're inexpensive, they're easy to deliver, and they can have a transformational impact on people's pain and suffering.
From the opioid perspective, we know that very little supply goes to low and middle income countries compared to what goes to high income countries. And also we know from the different evidence that the actual consumption of opioids has decreased from 2014 till 2024, actually globally. And this portends even more risk for palliative care where opioids is needed. So that is either showing a track down in high income countries where they are trying to reduce opioid consumption, but this reduction in high income countries is not flowing to low income countries where the need exists so that there can be a balance, and the consumption is actually reducing globally. So that is something that also we need to focus on.
What's the one thing that people should take away from this report? The one thing that would make a big difference and could tip the scales? Richard, do you want to start?
Yes, I mean, I do think within health systems, we need to see palliative care as health system strengthening, because it strengthens communities and enables people to stay in the community. It also strengthens health systems by reducing unplanned and non-beneficial admissions, and also the use of treatments which are non-beneficial. And to achieve that health system strengthening, we do need palliative care to be seen to be the responsibility of all working in health and social care, because palliative care as a specialty cannot and should not see everybody that has a life-limiting and life-threatening condition. That's not feasible. They are there to take complex cases, to give mentorship, training, education, but we really need palliative care to be trained and delivered as the responsibility of all.
So I would say really prioritizing that integration in low and middle income countries is where we are going to tip the scale, because that is where the need is.
There needs to be a reorientation to, rather than how can we solve this, how can we cure this, it's not about necessarily the quantity of life or extending life. It's about making sure that the time that people have is the best that it can be, and people can say what their goals are, and that we as healthcare providers, it's our job to do everything that we can to get them there. So if someone wants to see their daughter graduate from college, then that's more important than necessarily making sure that they live for 5 more years.
That was Paul Simpson interviewing Richard Harding, Oladayo Afolabi and Anna Peeler on their report for the WISH conference on how palliative care is overlooked in global healthcare. We'll link to both their report as well as the report on protecting health in armed conflicts in the show notes. That's it for this episode. We'll be back in a fortnight with more medicine and science. Subscribe so you don't miss out on any of it. Until then, I'm Cameron Abbasi. Thanks for listening.